Let's go through another EKG and look at the fine points and the not so fine points and the easy stuff and a little bit more of the hard stuff. Let's get one more under our belt here. As always, take a minute, look at this EKG, go through the algorithm, and come up with a final impression. Again, rate, rhythm, axis, intervals, ischemia or blocks, ischemia, infarct, any sort of patterns, and then give us a final impression. And again, take just a minute, pause the video if you need to come up with that answer. All right, hopefully that's given you a minute to look through here. Let's see what we've got. Starting off, as usual, rate. We'll take the number of QRS complexes in a 10-second strip, which this is 10 seconds long. So start down here in the rhythm strip, and we'll just start counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So that would give us a rate of about 60, and it looks like we almost get through another cycle, so we'll add on just a little bit of change for that, so 62, 64, something like that. What's the computer say? Rate of 65. All right, that's pretty close. All right, rate, rhythm. Is there a P wave before each QRS complex? It looks like in this case, it looks like that's P before QRS, P before QRS. Looks like we got likely sinus rhythm going on here. P before QRS, P before QRS, P's, P, QRS, P, QRS, P, QRS, P, QRS. Yes, so there's a P wave before each QRS and there's a QRS after each P wave. So it looks like this is sinus rhythm without any ectopy or anything like that we see. Rate, rhythm, axis. We could again skip axis if we really wanted to, but just to go through it. Lead 1, positive. Lead 2, QRSs are positive. Lead AVF, QRSs are almost split between them, but probably a little more positive than negative. So we'll say positive 1, positive 2, positive AVF. That'll be somewhere in the normal axis range, and this is probably actually, if you really wanted to look at it, since AVF, if you remember the direction, AVF points from the center of your heart down towards your feet, perpendicular. Since this is almost splitting that, this is probably almost perpendicular to that, so probably like a 0 degree or something like that. Anyway, long story short, let's just call it normal. Rate, rhythm, axis, intervals. Let's look at the 3 intervals we normally look at, or the 3 intervals that I normally look at that I found to be possibly helpful. So let's first look at our PR interval. The P wave to the start of the QRS, start of the P wave to the start of the QRS complex. That ought to happen within one large box. Does it happen in this case? Well, it about starts on the line here, and the QRS complex, starts before that second big thick line there. So we'll say that this looks like a normal PR interval. How about the width of the QRS complex itself? We'll call that an interval as well. That should be under 3 boxes, and let's find a good one to look at here. This looks like it starts about on the line. How many does it go through? Looks like 1, 2 little boxes. So 2 little boxes is under 3 little boxes, and so we'll call this a narrow complex QRS, which looks right to us. This doesn't look particularly fat or anything like that. And then let's look at the QT interval just to get an idea. We're not going to make any obvious calculations, but if we look at the R to R interval, the space between the little positive humps there, it looks like the T wave is all finished by halfway through that interval. So the space between those 2 R waves there is the T wave done by the time you get halfway between those, and that does indeed look like the case. So we'll say that this looks like a normal QT interval. So overall, normal intervals and no signs of a block, no signs of an AV block, no right bundle branch block or left bundle branch block or anything like that. Rate, rhythm, axis, intervals, and blocks. How about ischemia and infarct? Let's just run through these systematically. And the way that I like to do this when I'm scanning is I just kind of start going down, find the ST segment and the T waves, and I just look right there. Does that look normal? Yes, or more or less. It's maybe there's a little T wave inversion there, but it's not real prominent. It's mostly flat. How about here? Any ST depression or ST elevation or flip T wave? Nope. How about here? It's again, nope. And then scanning down through here, not really. Maybe there's an inverted T wave there. That might be old. Sometimes you see that. No obvious ischemia thus far, just a little T wave inversion there. How about when we go through the precordial leads? Let's see, lead V1, no. V2, oh wait, let's look maybe at this one here. Now, we know that we get a little bit of ST elevation in lead V2 kind of all the time. It's pretty normal to get at least a little bit of it. A millimeter, something like that is no big deal. But if you look at this one, what we see is that the QRS complex is really pretty small. It's only a millimeter tall, all told. And it looks like there's a millimeter of ST elevation there. And I will tell you, I'm concerned by that. When the amount of ST elevation is bigger, or at least as big, if not bigger, than the whole QRS complex, that's concerning to me. Let's see if we see anything else that looks concerning. Now, there's no obvious like tombstoning here or anything like that. The morphology is mostly flat, but I'm bothered by that. That looks like there's some obvious elevation there, and I'm worried that that's something that's bad. We get a little bit of ST elevation here again, not necessarily out of the realm of possibility out here, but it's still concerning that it's up there. And how about this guy? Here we see, you might be tempted to say this looks like a little bit of early repolarization, and certainly it could be, but I'll tell you that we'll say that this is not in a healthy young 24-year-old, but to give you a little context, in the setting of a 65-year-old male with chest pain, there is a millimeter of ST elevation there. That little notch there might make you think that maybe it's not legit, but I will tell you that I'm still a little bothered by that one. And then it sort of peters out here. So we have some ST elevation that looks a little funny to us. We have no obvious like ST depression out in the lateral leads, because this is, to run through this, where is it going to be located at? It's located in the septal leads, like V2, V3, maybe a little bit V4, so getting into the anterior leads as well. So anteroceptal ST elevation, we don't see over on the lateral aspect, or especially in the inferior leads, we don't see a lot of ST depression or reciprocal changes that we might think about. But in this case, this is a little bit concerning, especially given this elevation lead V2. So I'm going to say that there's some concerning ST elevation lead V2 through V4. Hard to say exactly what it means. I've been fooled before, but in the setting of I'm out in the field and this guy's got crushing chest pain, he's covered in sweat, I'm going to say this looks like concerning ST elevation. I would activate the cath lab on that, or at least call ahead for a STEMI alert. And if I'm wrong, I'm wrong. All right, so I'm concerned by that. Any patterns that we see otherwise? No, not particularly. No big peak T waves or hyperacute T waves or anything like that. Although potentially, if you look at lead V3, that might be a hyperacute T wave. It's a little big, and again, compared to the QRS complex itself, the QRS complex is maybe one big box tall or deep. And that T wave is, well, actually, it's a little more than one big box tall as well. So that might be concerning. So maybe that's a hyperacute T wave. It certainly would fit in with what we were thinking before, which is this might be an anteroceptal STEMI. And in fact, we did call the cath lab on these folks, and he was taken to the cath lab, and turns out had a sort of a distal LED occlusion, which seemed to be feeding like the septum and the anterior parts of his heart. So, right call. Hey, even a blind hog finds a nut every now and then, as my grandfather used to say. That's a little more context than maybe we're used to doing here, but that's how to go through this particular EKG and some of the stuff we see on it. It's a little bit subtle, but again, things to kind of hone in on, especially in a little tiny QRS complex with a amount of ST elevation that's as much or more than that QRS complex is. That's concerning. And then a big T wave that's as tall as the whole QRS complex is, that's also concerning. And of course, then there's the clinical condition of the patient himself. All right, that's what we got. Anteroceptal STEMI sinus rhythm on this one. Like us, leave any comments that you have below. Tell me how I'm wrong if you want, and we'll try to keep these coming out. Otherwise, stay safe out there, and we'll catch you next time.